welcome to EuroPCR 2025 here in Paris. My name is Thomas Keeble. I'm an interventional cardiologist at the Essex Cardiothoracic Centre in the UK. And I'm delighted today to be joined by Nilesh Pareek, an interventional cardiologist at King's College Hospital in London. Welcome, Nilesh. We're here to talk about NIRS IVUS today. Maybe you could tell me first what NIRS IVUS is, so for the people at home.
Thanks, Tom. So NIRS IVUS is a dual-modality catheter developed by Nipro. It's the Makoto system and the Dual Pro catheter, which integrates 35 to 65 Hertz IVUS, but also has NIRS, near-infrared spectroscopy, which can identify lipid-rich plaque. Briefly, it can identify areas of lipidic plaque, which are seen as yellow on the system, and you also get two digital outputs called the LCBI, the lipid core burden index, which ranges from 0 to 1,000. The higher the number, the more lipid in that region.
So maybe you could just elaborate a little more about the clinical evidence about how that helps you to sort of understand what they've derived so far.
Yeah, I mean, it's interesting. A couple of seminal trials, in particular LRP and Prospect 2, have shown that the higher your lipid core burden index in non-culprit plaques is associated with MACE at follow-up, somewhere between 325 and 400. The Prospect 2 study was unique, and it also showed that plaque burden from the IVUS was important, but actually that the lipid core burden index value, somewhere between, as I say, 325 and 400, actually had additive prediction. And then adding to that, we have a study called Pac-Man AMI, which showed that intense LDL reduction with PCSK9 inhibition led to significant reductions in LCBI. And what was really striking was that was then associated with improved outcome. So it really is clear that this catheter can identify the vulnerable plaque. So Tom, you know, I'm aware that you're one of the highest volume operators of NIRS IVUS. How has it changed your PCI practice?
Well, I think what I like about it is it democratises plaque vulnerability. So I think we can all look at IVUS images, OCT images, and I think unless you're a true expert, it can be challenging to determine exact vulnerability. I think the beautiful thing about the NIRS and the chemogram that you get is it's very clear. Yellow is bad. High numbers above 325, as you say, is associated with plaque vulnerability and worse outcomes. And I think it allows all of us very quickly, simply and easily to understand exactly the vulnerability of that plaque. Secondly, when you see that, I think it does change how you treat and stent vessels. So you will often stent very slightly longer to cover areas that are vulnerable. And because you know that if you leave that plaque vulnerability, you're more likely to run into trouble. So I think it allows really to personalise what you're going to do within that vessel, one hoping to deliver the best possible stent result for that patient longer term. And finally, if I see a really huge LCBI, so maybe more than 600, there's some very nice evidence that we should not post-dilate these stent results because we end up potentially with distal embolization and slow flow, and we know that that's often associated with bad outcomes. So I think it really allows you not only best-in-class IVUS with grade 1A indication, but also plus this chemogram and plus all that other evidence to support and personalise the way in which we treat our patients. If I could move on, clearly this is an exciting field. Understanding quickly, simply and easily in your workflow the vulnerability of plaques both in your culprit and non-culprit. How in the future might that work in our favour for our patients, and what is the future of plaque vulnerability and identification and treatment?
Yeah, no, it's a really exciting area at the moment. You know, identifying the vulnerable plaque through the NIRS IVUS system, I think, has many potential avenues. One of the most interesting, I think, is the potential for DCB therapy to apply localised drug at the vulnerable plaques. There's an interesting study called Debut LRP, which showed that at interval there was a significant reduction in the lipid core burden index, perhaps cryotherapy also. So I think you know, that's one potential area. We're both involved in our national NIRS IVUS registry, where we're hoping to link that with morphology and stent behaviour, linked with MACE at 2 years. So I think this is really a rich research field.
So if I were to summarise the three things about the NIRS IVUS technology and catheters, The first thing I would say is I think, and you'd agree, it's the best-in-class IVUS. It fits beautifully into our workflow and allows us to, with 1A indication, treat our vessels the best that we can. I think number two, it democratises plaque vulnerability and bespoke and personalises the way in which we treat both culprits and non-culprits to deliver the best possible results for our patient. And finally, I think, as you rightly say, there's a huge future direction of travel of plaque vulnerability and personalising how we treat that in the future with new technologies. And I think that's a really, really exciting field. Thanks very much for joining us. I hope it's been a fantastic session.
Thanks, Tom.